All right, as you know, I tend to get wordy towards the end of the quarter, so I have my stopwatch on and I'm trying to watch my time on these lectures for Module 9. So Module 9, we're getting close to the end of the quarter. We are going to be talking about Chapter 8, Structure and Function of the Vertebral Column. So of course, like we always do, we're going to start with osteology. So the learning objectives, and this is from the study objectives from the module, the learning objectives for this part of the lecture are to identify the joint types and motions available at each joint, just like we always do, identify the bony landmarks of each joint and their anatomical position in one another, just like we always do. And we will be palpating these on June 8th in lab. I want you to be able to describe the spinal curves and their functional significance, as well as the overall function of the spine. I want you to be able to relate the direction of spinal motion to the planes of the facets at each level. And we'll start talking about this in osteology, and we'll carry that on into the next couple lectures. I want you to be able to identify a typical, and I'll talk about what typical is, spinal vertebra, and what's typical at each level, cervical, thoracic, and lumbar, and what are its distinguishing features. In other words, how do you tell a lumbar from a cervical, or a thoracic from a cervical, or a thoracic from a lumbar? So I want you to know what the transverse foramina and the cervical vertebrae are and why they're there. Why do we have those in the cervical vertebrae but no place else? And what is the purpose of the sacral canal? So basically, we're going to talk about a typical vertebra from each area, and then about the special stuff. And I want you to be able to identify the special stuff. So we have in the vertebral column 33 vertebral segments divided into 5 regions: cervical, thoracic, lumbar, sacral, and coccygeal. Normally, in most people in giraffes, there are 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral, which are fused, so it becomes the sacrum, and 4 coccygeal segments, which are also fused. So they form individual sacral bones, or the sacrum as we call it, and the coccyx, which is the coccygeal bone. So we're primarily going to be talking about the cervical, thoracic, and lumbar regions, although we will talk about some landmarks on the sacrum. Some of them palpable, and some of them we use a lot in physical therapy for checking alignment and that sort of thing. So each of the 3 top regions, cervical, thoracic, and lumbar, allow flexion extension, lateral flexion, and horizontal plane or axial rotation. All of these really important to functional movements. So just like every other joint in the body, the motions available are largely due to the shapes of the bones in the area and the functions of muscular and ligamentous structures that shape or move or restrict movement in a certain area. So the normal human vertebral column has a set of natural curves that are shown here. So the sacrum has some slight kyphosis. The lumbar has some slight lordosis, which means anterior movement, anterior flexion. The thoracic has some slight kyphosis, and the cervical has lordosis. So the lordosis is a slightly extended posture in the sagittal plane, and kyphosis is a slightly flexed posture in the sagittal plane. So the anterior concavity of the thoracic and sacral regions provides space for vital organs within the chest and pelvis. So that makes sense. We need movement, we need space, we need to protect the important things in our body. And like I said way back in Chapter 2, I think, I'm talking about bone. The important stuff in the body is encased in bone. So the spinal cord is encased in bone. The brain is encased in bone. The heart and lungs are in the rib cage. They're encased in bone. So that's a theme throughout the body. So the natural curvatures of the vertebral column are not fixed. They're dynamic and flexible to accommodate a variety of different postures and movements. So I I've done some studying with a physical therapist named Sherry Betts, some continuing ed, who is a specialist in osteoporosis, and she's a Pilates instructor as well, and she's the physical therapy advisor for one of the major Pilates associations in the country. She's based out of the San Francisco Bay Area, but she comes up here and does workshops, and she's great, really interesting. So what we call, with this normal spinal curvature, we like to call neutral spine. And she said she doesn't like neutral spine, she likes optimal spine better, because neutral spine just doesn't excite anybody. It's it's sort of dull, neutral. But anyway, neutral spine is what we normally call it. And we had, in one of the workshops I did with her, we took a flexible curve, which it's like a ruler that has some flexible material in it. You can put it along your spine. We traced people's spinal curves. We drew them onto a piece of paper, and then we put all the pieces of paper from most curves to least curves, and it went from like, wow, that's really curvy, to wow, what is that, a yardstick? And I fell more on the wow, what is that, a yardstick end of things. But like I said before with measurements, what's normal for you, as long as you don't have any pathological processes going on, is normal. So just because you have a super curvy spine or a super flat spine doesn't mean there's something wrong with you. It just means that you're within the normal variation of spinal curves, which is, you know, kind of cool that we have that normal variation. Disease or trauma or genetically loose ligaments or habitual poor posture can lead to exaggeration or reduction of the normal spinal curves. So it can have implications on your breathing and on your muscles and joints. As we age, living in a gravity field like we all do here on planet Earth, the curves in our spine tend to become more pronounced. So you'll see people as they age, they lose height. Some of it's in their discs, some of it's from exaggerated spinal curves. If you have any not normal curvatures, like you have a slight scoliosis, it's probably going to get worse as you age. So that's just something to think about when you're working with elderly patients. And in physical therapy, a large number of our patients fall into that category. Not necessarily elderly, but aging. I mean, we're certainly all aging, because the alternative to aging is not good. So it's something to think about when you're looking at somebody's spine who is aging, as we all are. So the anterior concavity of the thoracic and sacral regions provides space for vital organs, which I already talked about, and the normal curvatures are dynamic and flexible. And they provide strength and stability to the entire axial skeleton. And remember, I said previously we need proximal stability for distal mobility. So our spine and core needs to be stable in order to have good mobility in our extremities. Okay, so look at all these motions that someone can do in their spine. It's lovely. So when the natural curvatures are maintained, or we have neutral spine position, compressive forces can be shared by stretched connective tissues and muscles. And it allows the vertebral column to give slightly under load rather than supporting large compressive forces statically. When people first started studying anatomy, it was thought that the vertebral column was very static, and that the bony structure provided its stability. And this is actually not true. Our muscles and ligaments provide a lot of the stability. And so when we have muscular or ligamentous dysfunction, it can affect our normal spine function. So the line of gravity passes through the mastoid process anterior to the second sacral vertebra and posterior to the hip and anterior to the knee and ankle. In this ideal posture, gravity helps maintain the optimal spinal curvature, significantly increasing the efficiency of static postures. And we have talked about this a little bit in regard to knee and hip alignment, and it applies to the spine as well. So it's really important to have good posture to maintain that line of gravity. And it's an energy conservation thing as well. So there's tons of great bony landmarks on the cranium that we're not going to talk about, and we're not going to palpate. We are not going to, even though they're included in Chapter 13, the muscles of mastication. We are not going to talk about the facial muscles because we do not treat that a lot in physical therapy. If you're working with someone on temporomandibular joint dysfunction, it's considered an area of specialty, and it's not necessarily an entry-level skill. So you'll want to know more about those muscles, but we are not going to talk about them in this program. So the three main landmarks that I want you to be able to palpate and know on the cranium are the external occipital protuberance, or simply occipital protuberance. And most people you can feel it on. If somebody's got long or really super thick hair, it's a little harder to find, but you can find it on most people. And people who have really short hair, it's really easy to find. It's located at the midpoint of the posterior skull, and it serves as an attachment for the ligamentum nuchae and the upper trapezius. So your upper trapezius goes all the way up there. Crazy, right? So this perionuchal line is a ridge of bone extending laterally from the occipital protuberance to the mastoid process. And the mastoid process can be found right behind your earlobe, and very easily palpable on, I'm going to go out on a limb and say everybody. The mastoid process, it serves as a cranial attachment for numerous muscles in the head and neck, and we'll talk about them all in a little bit, or in the next lecture. And it's really super easily palpable, a good landmark to find. The inferior nuchal line is not as easily palpable. It's near the base of the skull, and it provides cranial attachments for a lot of different muscles, like the suboccipital muscles and ligaments of the posterior cervical region. So it's palpable, but it's not as easily palpable because of that band of muscles over it. The foramen magnum is not palpable. If you can palpate your foramen magnum, then call 911, because it's not supposed to be palpable. It's located at the base of the skull, and it provides a passage for the spinal cord to go up into the brainstem. So there is a disorder that's called an Arnold-Chiari malformation, where your brainstem is coming out through your foramen magnum, and there are a lot of different causes for it. Sometimes it's congenital. There are a couple other reasons that could cause it, and that's a big deal. It's a serious thing. Needs to be treated with surgery. The occipital condyles, which also cannot be palpated, are on either side of the foramen magnum. They project from the anterolateral margins of the foramen magnum and form the atlanto-occipital joint with cervical vertebra number 1. So I'm going to end this right here, since we're getting close to 15 minutes. And in the next section, we're going to start talking about the vertebrae and their bony landmark features.